Thank you for the introduction, dear Chairman. So the next 10 minutes I will focus on patient selection for focal therapy, radiological perspective. These are my disclosures. So I want to start off with a case. This is a 72-year-old male with a PSA of 7.1, Gleason 3+4. 4 out of 12 biopsies were positive in the peripheral zone on the right side with a tumor volume of 45%. And if you have a closer look to this image, then you can appreciate the lesion in the right peripheral zone as annotated by the yellow circle both on T2 and diffusion. And the first question to you is, what kind of therapies would you advise? A radical prostatectomy or radiotherapy? Or this patient should opt for active surveillance? You don't believe the biopsy result based on the imaging findings, so repeat and do a target biopsy or opt for focal therapy as a possible solution to treat this lesion. As mentioned before, current standard of care in low and intermediate risk prostate cancer range from active surveillance, mainly done in ISAP1 and ISAP2 with a small 4 component, or radical therapy by using radiotherapy or prostatectomy, with a higher chance of morbidity and decreased quality of life if you do active treatment, resulting in urinary incontinence, erectile dysfunction, and in case of radiotherapy, bowel toxicity. Focal therapy or partial gland ablation may play a role in ISAP2 and 3 patients for treating the lesion. According to the European Association of Urology, active therapeutic options outside surgery or radiotherapy could be focal therapy with HIFU or cryotherapy, however, within a clinical trial or prospective registry. The discussion about focal therapy versus partial gland ablation, in my opinion, most of the cases described in literature are partial gland ablation, but we focus on the lesion with a certain margin around it. And that's also visible over here. In this location, for example, in the left peripheral zone, you can clearly see the lesion with a certain margin around it, but in most of the cases, the margin is either a quarter or even a hemiablation. So the idea of focal therapy and partial gland ablation is to have less side effects by treating the cancer while preserving key anatomy responsible for urinary and sexual function. And as mentioned before, there are different tools and several tools available for doing the job. In this literature review we did 2 years ago on what kind of therapies are available for focal therapy and what has changed over the past 5 years. And what we found is that there are no differences in oncological outcomes and quality of life between the various energy modalities. And what we also found and what we also know is that there's a lack of phase 3 trials or RCTs, so the evidence is still lacking. So what are the prerequisites for imaging-based minimal invasive treatments? Preoperative treatment planning, intraoperative imaging feedback, so we have to see where the needle is placed inside the tissue, intraoperative verification, so where is the lesion located and how is the ablation zone, and also important outcomes. So after therapy, when a patient comes back for follow-up imaging, we have to have an idea about the outcome of those of the treatments. So what are the possible hurdles for focal therapy or partial gland ablation? From the radiology point of view, we know prostate cancer multifocal disease, accuracy of imaging. What about the histological volume? Which patients will benefit from focal therapy and which patients will not benefit from focal therapy? And as mentioned before, multifocal disease, also for example, with breast cancer, is also multifocality. It's a Frinke phenomenon. And the idea is in prostate cancer that we use the index theory. So the lesion, which is the large and most aggressive, will also have most likely the potential to metastasize. And if we can pick up the index lesion within the prostate and treat it, we might also cure the patient. Several papers have shown that if you use MRI before the biopsy, you can accurately detect the cancer. In this interesting paper from a group in London, they looked at the lesions inside the prostate. It was a retrospective review on index lesions and histological prognostic features. And what they found, if you look at the unifocal lesion or index lesion, they tend to be more aggressive, whereas the secondary lesions tend to be low Gleason score, so Gleason 6. And also, if you look at the extracapsular extension, it's less frequent compared to the unifocal or index lesion. So this is very suggestive. If you treat the index lesion or the lesion which is the larger, most aggressive, you also most likely can cure the patient. Accuracy of mpMRI, several papers have shown if you use for example, diffusion and T2, you clearly can find the lesion inside the prostate. Especially if you look at focal therapy, we're focusing on patients with ICEP 2 and 3 lesions, which can be picked up with MRI. What about histological volume? I think very essential. I always say we can pick up the lesion, we can see where the lesion is, but mainly we see the tip of the iceberg. So with T2, so anatomical imaging gives us under and overestimation of the true tumor volume. Diffusion-weighted imaging yields the best correlation between MR and histological tumor volume. And based on these two papers, they've shown that what you see on MRI, you need at least 9mm treatment margin around the visible lesion to ensure treatment of the entire histological tumor volume during focal ablation therapy. So under treatment is associated with a poor prognosis even after salvage radical prostatectomy if the recurrence occurs in field. And that's really important to understand. So you have only one option or one chance to treat the lesion. The learning curve for focal therapy is also non-trivial, and residual malignancy after focal therapy may indicate a phenotypical worse disease associated with a poor oncological outcome. So coming back to another patient, this lesion visible here in the peripheral zone, annotated with the arrows, you can clearly see it. And if you do a treatment planning, you shouldn't focus on this particular lesion. You should have a margin around the MR visible lesion, in not only in 2D in the axial plane, but also in the sagittal plane. And this helps you to identify which patient can be helped with focal therapy. For example, in this case, it's a unilateral disease, ICEP 2, however, it's broad tumor contact. So this patient might not be a very ideal candidate for focal therapy. So to consider PSA is not a validated biomarker for surveillance after focal therapy, that's our biggest problem. The follow-up using MRI plus targeted and systematic biopsies are recommended. I didn't discuss the role of PSMA PET, but for sure that's something we see also in our clinical practice that's increasing. And the question is, where should we use PSMA PET in which patient group? Coming back to my patient and one of my last slides, this is still a lesion visible on the right side. And my question to you is, and I hopefully could convince you that this could be a patient for focal therapy. RCTs again they are recruiting. Several RCTs are underway. They are recruiting patients, and I'm looking forward to the preliminary results of those studies because we need evidence. So to conclude, image guide techniques for target ablation of prostate tissue are available. Imaging and biopsy play a very important role in patient selection, and the need for RCTs comparing safety and efficacy of the focal therapy with standard of care is growing. Thank you for your attention.